We're delighted to have Professor Lorna Fraser here with us this morning, who's a Professor of Palliative Care and Child Health at the Cecily Saunders Institute of Palliative Care at King's College in London. Lorna is an international expert in paediatric palliative care research and developed the methods underpinning the Irish prevalence study that Samantha has just spoken about. Lorna participated as a research partner in this project and is going to provide some international context for the work and the importance of this research in children's palliative care. So thanks so much, Lorna.
Thank you very much. It's an absolute pleasure to be here. I feel almost like an honorary Irish person because there's so many friendly faces in the audience. Before I start, I just wanted to... My overall aim is that the care for our most seriously ill children, wherever they are in the world, is based on the highest quality research evidence. And it's been a pleasure to play a very, very small part in this programme of work that has been led with scientific rigour, absolute professionalism, and showing the collaboration and the will across academics and service providers and parents to really understand better how in the Irish context, you care best for your most seriously ill children. And I think it's really important that's acknowledged today. So well done, Samantha and team. So Samantha gave me a long list of things to talk about, and I can't talk about all of them. I'm desperate to talk about lots of other things like parent experience and how we care best for families and things, but I'll try and stick to the brief, which was to talk about prevalence of life-limiting conditions in children. So this is really, really important from a policy point of view. You may be aware of the kind of challenges we have in our National Health Service. It's one of our most precious assets that really is at risk in the United Kingdom at the moment. And last year, our government produced the 10-year health plan, and one of the first, I think it's a policy, but they call it a modern service framework, is around how we deliver palliative and end-of-life care for all ages. And we're really being able to utilise our evidence to inform that. But also, you may also have seen the debates around the assisted dying legislation, both in Scotland and England, neither of which have passed, but it has been an opportunity, and there's been some policy-relevant pieces of work. The Palliative and End-of-Life Care Commission and the Health and Social Care Committee of the Government have both done reviews highlighting both the importance of palliative care for all, but also highlighting the real challenges at how best we deliver palliative and end-of-life care for children and young people. And again, the importance of the evidence in helping policymakers and practitioners understand how we best use finite resources to care for as many children and young people is where research like what Samantha and colleagues have been doing is so important. I'm aware we've got funders in the room, so I just wanted to put this slide up to say that, yes, it is important. We absolutely need to understand about the population and their needs, but we also need more evidence on service models, how interventions and evaluating those as well as evaluating policy. Because if we really want to provide holistic, child and family-centred care, we really need to, again, understand how best we do that. I was asked about where it all started, and I was trying to remember. This is Martin House Hospice, which was the second children's hospice in the world when it was launched, and I think it's going to be 40 years old next year in 2027. It's actually just been rebuilt, so it doesn't look anything like this. I need an updated photograph. But back in sort of 2008, 2009, the chair of the Board of Trustees at the time was a paediatric oncologist, and he asked some colleagues at the University in Leeds, I know exactly how many children have cancer in the region. Why on earth can you not tell me how many children have life-limited conditions? How many children, do we need to build our service around? And the only information we could give at the time was information on death certificate data. And my clinical colleagues were very quick to jump in and go, the end-of-life care is a really important part of what we do, but it only tells part of the story. We need to, we really need to understand about the children living with life-limiting conditions in order to better develop services. And actually, we went on to show that even if you use death certificate data, you're still underestimating the need because it's not as well recorded as we would like. So we thought, well, what can we do? What data exists? So there's the hospital data that Samantha's already mentioned. They're there for financial purposes predominantly, certainly in England. But we do have information when children are in hospital, when they have an outpatient or an emergency department admission. What is stored nationally is quite limited because it's coded data about diagnoses, about procedures, but there is some information about demographics. And one of the reasons it's so important that Samantha and colleagues have done this piece of work is the demographics of the population are quite different, even across the UK, but certainly different between the UK and Ireland. We do have the ability to link individuals. Unfortunately, NHS numbers and CHPI numbers, which is what we have in Scotland, are not a unique identifier. There are some occasions when those will change. So if a child is adopted, gender identity changes, etc., they can change. So they're not as good as we would like, but we have that ability to link. So we know which individual child is within the same data set. We don't know who the child is, but we know that that's the same child within those data. And we obviously, as Samantha mentioned, need population level data for prevalence. And then we just, how do we decide which children have a life-limited condition? We worked with information from Martin House. We had, I think, 2,500 children who'd been referred in the time period. And we also had some work done by Richard Hayne and your very own Mary Devons, who's in the audience somewhere. I've lost Mary. So actually, Ireland were very important in the development of this list as well. And really, we came up with a list that we could identify the codes within the data if a child had a life-limiting condition. Now, my life would be much easier if each diagnosis had its own code, but they don't. They're grouped in certain ways. So we had to make some assessment with our clinical colleagues about whether the majority of children with these codes were life-limited or life-threatened before we went on to use them. But this is what we've done. And some may say I've made my career off of it, doing long division, but I do other things as well. But we started off doing this report, which was funded by Children's Hospice UK actually at the time, across the 4 nations. And Samantha's talked about UK. We actually have 4 different NHSs, maybe more than that actually, because I think there's different NHS within England. So the data are slightly different. There are some similarities, but they are slightly different. So the first report we looked at all 4 nations. Then my homeland asked us, the Scottish Government asked us to do a bit more detailed information, not only about the numbers, but also about the needs of families and hearing from families as well. We came back and did it again in England, and then the Welsh Government decided they would like us to look more specifically at their population. Scotland and Wales both have better data, already pre-linked, much easier to access. And then more recently, we've just updated the data last year in England, and there's academic papers if people are interested. I've also worked with numerous academic teams across the world. This is a bit complicated. All I really want to show you here is this is data for Scotland. We had inpatient data, we had birth record data, which actually is all admissions aged up to 1. Why somebody called that a birth record, I'm not entirely sure. Outpatient data, death certificate data, cancer register, ICU, community prescribing. We had a lot of detailed information that we could pull on that enabled us to do things beyond just describing the number and the prevalence of children. In England, it's slightly different, not quite as good, unfortunately. But again, we have inpatient, accident and emergency, community prescribing, and death certificate data. Very similar to what Samantha's already shown, we identify children who have one of these codes coded at some point in their life, and they've had a hospital admission in a year, and they are within our cohort of children. I'm going to show you I'm going to jump around a little bit with the different countries just to demonstrate some different things we've been able to do with our data. We weren't as smart as Samantha and co. We did include COVID in our graph, and any prizes for anyone spotting where it is. But what you can see here is over a 20-year time period, the number of children in England with a life-limited condition increased from just over 31,000 to nearly 89,000. Now, even if you ignore the COVID blip, it looks a little bit like that may have plateaued, and that may be real. It may be that actually the numbers of children living with life-limited conditions has plateaued, but we won't really know until we've got a few years more data, because as Samantha said, certainly our hospital use, particularly our intensive care use, is not reverted back to pre-pandemic levels even yet. But this is a marked increase over this time period. The other thing I meant to say at the beginning, apologies, is remembering I'm showing data here, but behind these data points are individual children like Cian and families, and so important that we remember that when we're looking and talking about these data. Again, similar to what Samantha's shown, higher prevalence in the under ones, but we've already heard the importance of transition to adult care. You can see even in the 16 to 19 year age group, we're still seeing a marked increase over that time period. You know, our colleagues in acute medicine, acute surgical are really good at keeping children alive longer. Are we as good at helping them thrive in society and our broader health and care system? Something for us to think about. Again, if we look at individual diagnostic groups, congenital anomalies, so children with neurological conditions and cardiac conditions predominantly. We also have children with neurological conditions that are not congenital, and respiratory conditions. Perinatal, some of you may see, is the orange line that goes up quite markedly. I don't think that's real. I think that's just we've had a lot of investment in data collection around the time of birth in our maternity services. I think we're better at recording things, not that we're getting worse at caring for newborn babies. Inequalities is really important when you're thinking about planning services. This is the most recent data from England. These are 5 equal categories, so if children with life-limiting conditions lived equally in society, there'd be 20% in each category, and you can see there are more children living in areas of high deprivation and less children living in areas of lower deprivation. And we also see a markedly higher prevalence in some of the ethnic minority populations living in England, Pakistani, other Asian, and our black populations. And some of these are easily explainable by genetic conditions. We know work from Born in Bradford study, for example, the impact of consanguinity on congenital anomalies. But these are really, really important when we're thinking about flexibility and accessibility of services for all children and families. And I'm aware the demographics are different in Ireland, but I'm sure you have populations in which you need to think very carefully about how flexible your services are to care for all. And neither of these tell the story. So this is one of our original analysis looking at intersectionality. So even within the South Asian population, for example, in the middle, you still see a gradient by deprivation. So the prevalence is still higher within the more deprived South Asian groups compared to the less deprived South Asian groups. And if you flip that round and look within deprivation categories, even within the most deprived category, it's still markedly higher prevalence within the South Asian and black populations than in the white population. So we mustn't remember that cumulative impact of intersectionality on children and families. We've already heard from Orla about the things you have to juggle and all the care needs that Cian has. Adding in challenges around finances, challenges around culture and other things, can be really, really challenging. As Samantha said, this isn't just about numbers of children with particular diagnoses, though, and we've attempted to try and look beyond diagnosis in a couple of ways. So firstly, when we did the work for Scotland, we were looking at stage of condition. Some of you may be familiar with this terminology. It arose from Australian adult palliative care colleagues looking at clinician reporting of whether someone was stable, unstable, deteriorating or dying, and then using that to decide how much resources that individual might need. We flipped it around and looked at the resources that children have used. So we're saying that if a child's in ICU, they're deteriorating. If they've got an emergency admission of more than 2 days, they're unstable. These are quite arbitrary and slightly constrained by this relatively small population in Scotland for issues of identifiability. But what that was from Scotland, and the results are actually from Wales, so it's helpful. But same analysis. But a third of children with life-limiting conditions experience at least one episode of clinical instability in a year, but that wasn't equal across all age groups. So again, the under ones, about 50% of them were stable in a year, more were unstable, deteriorating or dying. And again, when we mentioned transition earlier, you can see the group who are next most likely to be unstable or dying are the 18 to 25 year age group. That young adult population is so important. And I don't think we really understand how best we care and support young adults with life-limited conditions, particularly those who have been diagnosed in childhood. The deteriorating, just a small point, we didn't have ICU data, so the 18 to 25-year-olds are missing from that. I'm going to take a deep breath now. Samantha mentioned complexity. We tried to look in the data from both Wales and England and whether we could talk a bit more and capture and quantify complexity, because my clinical colleagues are always telling me the children that we look after now have much more complex needs than the children we looked after even 10 years ago, far less thinking further back. And this complexity wheel was developed by, the inner parts of it developed by Isle Cohen and colleagues, a paediatrician from Canada. So the 4 quadrants of having long-term conditions, high healthcare use, functional limitations, and family needs. What I would say is the things in grey are what we didn't have any information on because we don't collect it in our routine data, but are really, really important. So family identified needs and severity of limitations. We did have information on diagnoses, we had information on polypharmacy, so the number of drugs a child takes, lots of information on healthcare use, and a little bit of information on technology dependence in terms of whether children had a breathing tube, a feeding tube, home oxygen, etc., although that was less well coded. And what we did was essentially for each of the 5 categories, you could score 0 or 1. So it was a very, very simple method. And what we showed, this is data from Wales, actually there's a range of complexity across children with life-limiting conditions, and that increases a bit with age. It doesn't work very well for under 1s. You've got to be out of hospital before you can be readmitted. You've got to be a certain size before people are going to start putting tubes in, etc. So I don't think it works very well for that group. But it certainly, you know, for the older population, it shows the range of complexity. And we looked at complexity by stable, unstable, deteriorating or dying, and I think it was interesting that you did see increase in complexity in unstable and deteriorating compared to stable. You didn't see it in dying, it was a bit of a mixture, but again, that's because about half of children who die are under 1, and we know it doesn't work very well for them. But on the right-hand side, you can see in the older children who have died, there is, you know, it is children with the higher levels of complexity. We've just been doing this within the English data, and I think this is a graph that really shows the increase in the number of children with technology dependence. So back in 2003, there was about just over 3,000 children who were gastrostomy fed, and it's now nearly 17,000. So just one measure, it's not the only measure, but an important measure to show actually the increase in the numbers of children with complex needs. This slide is probably the slide that really has, amongst my policy-making colleagues, has made people really, really think. Maybe one child in every primary school might have a life-limiting condition, but when you go on to the right-hand side, 7 beds in our paediatric, out of 10 in our paediatric intensive care units are currently caring for children with a life-limiting or life-threatening condition. Now, these are our most resource-intensive and sought-after beds. At the moment in the UK, there will be children that were being transported across the country because there isn't a bed locally for them to be cared for. Now, for many of these children, that's a very appropriate place to be. That's where they need to be. But we also have scenarios where we don't have good, safe care outside of intensive care for children. And we really need to, again, think about how our health and broader health and care system can care better for children with very high needs safely, and also supporting the family in that role as well. I won't go into detail this, although this is full population data, and it's repeatable. We've seen Samantha's been using some of it in her work, and we can look at trends over time, but we are reliant on the quality of the data. You know, if the data aren't good enough, then there's only a certain amount that we can do. And I really want us to remember that we really don't have good measures at the moment about family needs and social complexity, which are really, really important. Again, policy is so important. These data were used by Lord Darcy in his independent investigation of our NHS last year. There was only 2 groups of children he highlighted within this report, and children with life-limited conditions were one of them. The report from Scotland was used by the Scottish Government to invest a reasonable amount of money in the children's palliative care sector in Scotland, and more recently the updated data from England has been used to distribute our hospice grant. So these are so important, and policymakers want information. They don't have to go and look for it. They want you to provide information in a digestible format that helps them make decisions. So the fact that you're at the point of looking at your new policy and the information you now have from the Irish context is timely. I also just wanted to talk a little bit about the changing population. If you look on your news website every day, there will be a new drug or a new potential treatment for some of the very rare conditions that children have. Some of these are fantastic and we know have certainly changed short-term outcomes. We're less clear about long-term outcomes for children and families, and palliative care still has a really important role to play here, particularly while we're in the period of not understanding the longer-term future. And newborn babies are a really good example of that. We now will routinely resuscitate babies at 22 weeks gestation within the UK, and the British Association of Perinatal Medicine and the Association of Palliative Care produced a new framework a couple of years ago, recognising that actually this is certainly newborn babies. This is less about diagnosis. This is more about the uncertainty of being premature. You may also have a congenital anomaly or another condition, but actually there's a really large population of babies who would benefit from a palliative care input at the same time as they're benefiting from intense neonatal care. So again, Samantha's already highlighted that population as an important group within Ireland to think about. Together for Short Lives, our national charity in the UK, have helpfully or unhelpfully, depending on whose shoes you're in, just decided to update our definitions of children and are talking about children with life-threatening and life-shortening conditions, and also children with severe medical complexity. These make a lot of sense from a clinical point of view, trying to really be much more specific about the population of children who might benefit from palliative care. Does provide us some challenges with available data, and we're just trying to work that out at the moment. These are all available on the Together for Short Lives website, with some clinical examples that I couldn't fit on the slide. So in summary, I think routine data are helpful, particularly for population level planning. It does, I entirely agree with Samantha, it's not just about children with particular diagnoses. We need to be thinking about complexity of needs, both in terms of the number of children that might need a service, but also what the service needs to be able to provide to help that child thrive and that family to care and be a family. But we do need better data. I don't think we've got it sorted in the UK. If you've got any way to look for any sort of unique identifier within Ireland, I think that would help across the board, not just within children's palliative care. But just to acknowledge the children and parents that work with us all the time, as well as our funders. Thank you very much.